Hello everyone, today we are going to revise some pharmacology. So here are few questions or few things which we have to remember. So this video might be in parts because the pharmacology is a vast subject, but I'll try to make as compressed video as possible and include the most important things which has to be remembered. So let's start our revision together because I am also revising these information. So let's start. So first of all, local anesthesia, it is a very important subject. Largest category of local anesthesia questions focuses on your ability to distinguish amide allies from esters. So esters are most people remember it as more as a uh, three parts like procaine, cocaine, tetracaine. So these three are esters, and now mostly people remember name of the esters and other all the local anesthesias are amide. So it is easy to remember during the question that whatever esters are there, and we can easily figure out the other all options will be amides. So this you will get to know later on when we will start going deep into this topic. So now the esters are procaine, tetracaine and cocaine. Amides are metabolized in liver, but the esters are metabolized in the plasma. But it is not 100% sure that they only metabolize in plasma. A little bit of them can also be little portion can also be metabolized in liver, but we take the significance of the larger portion which forms its actual characterization that it is an amide and it is an ester. Now the next thing which has to be remembered is prelocaine is a local anesthesia which is an amide. It causes methemoglobinemia. Okay, so it is related to a condition called methemoglobinemia. Then another information which has to be remembered is only the non-ionized or free base form can penetrate the tissue membrane. Inflamed tissue has a lower than normal pH, which decreases the amount of non-ionized form available to penetrate. Hence, the local anesthesia cannot penetrate the tissue which has inflammation and cannot anesthetize that area. So this is the reason why during an infection dentist will prescribe antibiotics to lower down the infection of that surface, so that if he has to work on that side, then they can administer local anesthesia and that local anesthesia will work. Otherwise it will not work because of the lower pH of that particular area. Now let's move forward. Now there is an information which I have told you that esters do majorly metabolize in plasma, but it is not 100% sure that they only metabolize in plasma. They can also little bit metabolize into the liver as well. Now this information is illustrated as procaine is an ester. Esters are metabolized predominantly by pseudocholine esterase in the plasma, but they can also be partially metabolized in the liver, but in very negligible quantity or small quantity. Hence it is said that predominantly it is metabolized in the plasma by pseudocholinesterases. Now the next thing is let's move forward. Now the another important point which I have noted in my notes is, according to textbooks, local anesthesia fall into the following classes in term of duration of action. First one is short acting. Procaine is the one which come into this. Then comes the moderate. This forms prilocaine, mepivacaine, lidocaine. Next is long acting. The one which is in this these are bupivacaine, tetracaine, atidocaine. Okay, so short acting or the duration of action which have which have a very short duration of action is procaine. Okay, next moderate duration of action is in the prilocaine, mepivacaine and lidocaine. The another one is long acting which is bupivacaine, tetracaine, atidocaine. So lidocaine comes in the moderate acting, and we know that lidocaine is the most extensively used local anesthesia in the dentistry. So we should remember that this is a moderate acting. The next point is propranolol interacts with lidocaine in two ways: by slowing down the heart via beta blocker receptor blockage, and blood delivery to the liver is reduced. Thus, lidocaine remains in the systemic circulation longer and can potentially accumulate the toxic levels. Propranolol and lidocaine also compete for the same enzyme in the liver. Thus, metabolism of lidocaine can be reduced. Okay, so the duration of action of lidocaine would be increased in the presence of propranolol. Okay, duration of action of lidocaine is increased in the presence of propranolol, because propranolol will slow down the heart by doing beta receptor blockage, and then it also competes with lidocaine in liver to get metabolized. This will cause increased duration of lidocaine in the system, and due to this excessive duration, the lidocaine can achieve the toxic levels. So it is not suitable with each other. Another important factor, the next point is, see, we know that esters predominantly are metabolized by the plasma, and amides are metabolized by the liver. So the liver disease or the liver related any problem will affect the metabolism of amides, and obviously will not metabolize them, and the duration of action will be increased, and it can cause the toxicity as well. But in these cases, what we have to do, maybe if a patient is having a liver disease and we have to do some procedure and they require anesthesia, so we would not be preferring amides, but we will be preferring esters, as the esters get metabolized in plasma, and it is not an issue if a person is having a liver disease. So that is important, because esters are the local anesthesia which causes allergic reactions, but still we think that why it is existent in the practice, if it is so allergic and mostly causes allergic reaction and everything. So that this is the reason where there are certain conditions in which we cannot use the normal local anesthesia or the extensively used local anesthesia. At these conditions we have to carry the other options. Now the next point which is important in pharmacology local anesthesia is use of prilocaine carries the risk of which of the following adverse effect? So the options are porphyria, renal toxicity, gastric bleeding, methemoglobinemia. So use of prilocaine causes the methemoglobinemia. It is very important to remember that prilocaine causes methemoglobinemia. The next one is high plasma levels of local anesthesia may cause depression of inhibitory neurons in the central nervous system. Initially, LAs inhibit central inhibitory neurons, which results in the central nervous system stimulation, which can proceed to the convulsions. At higher doses, they inhibit both inhibitory and excitatory neurons, leading to the generalized state of central nervous system depression, which can result in respiratory depression and death as well. So very high plasma levels of local anesthesia are very harmful. If a question arises, this can also be quoted as, unfortunately you injected your lidocaine intra-arterially. The first sign of lidocaine toxicity that might be seen in the patient would be A. Elevated pulse rate, B. Sweating, C. Central nervous system excitation, D. Cardiovascular collapse, and E. Central nervous system depression. Now we know that firstly the excitement happens and then the central nervous system depression occurs, which can again lead to respiratory depression and everything, which we have just discussed. So in this question the answer is central nervous system excitation. Now, the first sign that a patient may be experiencing toxicity from too much epinephrine would be A. Cardiovascular collapse, B. Convulsions, C. Elevated pulse rate, D. Slurred speech. It is a sympathomimetic after all the other reactions are related to elevated lidocaine levels. Now, the C is the right option, which is elevated pulse, because it is related to the epinephrine. The cardiovascular collapse, convulsions, slurred speeches, all are related to the local anesthesia toxicity or complication. Now another important question is, which disease condition would make the patient more sensitive to the epinephrine in the local anesthesia? Graves' disease, diabetes, HIV, alcoholism, schizophrenia. Most sensitive to the epinephrine. It is Graves' disease. Graves' disease is an autoimmune disease that causes hyperthyroidism. The resulting high level of circulating thyroid hormone result in a hypermetabolic state with heightened sympathetic activity, which combined with injected epinephrine could result in a hypersensitivity crisis. Next question is, cardiovascular collapse elicited by a high circulating dose of a local anesthetic may be caused by syncope, vagal stimulation, histamine release, myocardial depression, or medullary stimulation. The right answer is cardiovascular collapse is due to a direct action of the local anesthetic on the heart muscle itself, LAs in toxic doses depress the membrane excitability and conduction velocity. Thus, D is the correct answer, which is myocardial depression. All of the other alternatives are indirect way to affect the heart. Now next one is, which is very important question, is hypotensive shock may result from excessive blood levels of each of the following local anesthesia except cocaine, procaine, lidocaine, tetracaine, mepivacaine. All the listed local anesthesia except cocaine are vasodilators, especially ester type drugs such as procaine and the amide lidocaine. Cocaine is the only local anesthesia that predictably produces vasoconstriction. So it is very important to note that cocaine is a local anesthesia which causes vasoconstriction. It is also only local anesthesia to block the reuptake of norepinephrine into adrenergic neurons and thus potentiate the norepinephrine that has been released from the nerve endings. Let's see what is next in this. Local anesthesia work in a way to prevent the generation of a nerve action potential, and this is mostly done by the sodium channel blocking, and hence the impulse does not occur and does not take place, and the sensation of that area gets disrupted or gets a loss. Another important thing in local anesthesia is, remember, the free base or non-ionized form is the form that passes through membrane, yet once inside the neuron only the ionized form is effective. Inflamed tissue has a lower pH than normal tissue and will shift the equilibrium of the local anesthesia solution such that most of it remains ionized and thus unavailable to penetrate. At a pH of 7.8 lidocaine, pKa is 7.8, will exist in, this is a question, so will exist in an ionized form, non-ionized form, equal mixture of ionized, non-ionized, or a mixture 10 times more ionized than non-ionized form. So answer is C, which is the ratio of ionized to unionized form is given by the formula log A upon AH is equals to pH minus pKa. In this instance, the difference between pH and pKa is 0. Thus, lidocaine will exist as an equal mixture. Okay. Most local anesthesia are weak bases with pKa ranging from 7.5 to 9.5. LAs intent for injection are usually prepared in salt form by addition of HCl. They penetrate as unionized form into the neuron where they re-equilibrate to both charged and uncharged form inside. Okay. Now the next is about the antibiotics. Penicillin V versus penicillin G. So let's do the antibiotic in next video. So see you in next video.